So thank you, Sanjeev ji. Here I go once again, and this time it is on COVID-19 and the myocardial injury. This is the very first report that appeared from Wuhan, China. And as you can see here, that older the people and the people who had cardiovascular disease or who had the risk factor for the cardiovascular disease, they were more frequently affected by COVID-19, and there was a much higher need for admission to the intensive care units. It was subsequently confirmed by the CDC China that the mortality rate was much higher with the increasing age, as also it was much higher as compared to the standard mortality. It was much higher in people who had either cardiovascular disease or they had the risk factors for the cardiovascular disease. Now, once the COVID infection sets in, it basically interacts the spike proteins of the SARS-CoV-2 that interacts with the ACE2 receptors on various cells of the body. And that is its portal of entry into the cell. It requires yet another molecule, which is called the co-stimulatory molecules, which will be such as the TMPRSS2. They help the entry of the SARS-CoV-2 into these cells, as you can see here, that they cleave the spike proteins and the virus enters into the cell. Now, as you can see here, the virus is entering through the tracheal epithelium. You can see it in the electron microscopy here. The coronavirus is into the epithelial cells. And in the lower panel, you can see that the coronavirus is present in the alveolar spaces and is entering into the pneumocytes, particularly the pneumocyte type 2, which have abundant ACE2 receptors. Now, from here, essentially, the most important thing that happens is the breach of the barrier between the alveolar epithelial lining and the endothelial lining of the capillaries which surround these alveoli, and it goes through the interstitial spaces between the epithelium of the alveolus and the endothelium of the capillaries. And as you can see here, that the epithelial lining has almost lost, and quite a bit of the interstitial capillary lining is also disappearing. Or as you can see in this cartoon also, that these are the pneumocytes type 2 where the coronavirus infection has occurred. And you can see that through the interstitial spaces, the viruses may be able to penetrate into the endothelium of the capillary vessels or even get into the blood stream. Now, at this point in time, there are leaky capillaries, and they can also cause the formation of the hyaline membranes. So, as the alveolar affliction is occurring, there is a possibility of the diffuse alveolar damage with the acute hyaline membrane formation. You can also see that there would be an organizing phase, as you can see here, after 3 to 4 days. And here, these are the giant cells, and there is a reactive pneumocytes which have started to form. And the formation of the pneumocytes may not be as effective. This is the perivascular lymphocytic infiltration. And here you can see the presence of the spike proteins in the macrophages of the alveoli, as well as in the epithelium of the alveoli or the bronchial and other airways. Now, once the viruses are in the bloodstream, from there they may get into the enterocytes or into the GI tract, which also has abundance of the ACE2 receptor. So also in the kidney, for example, in the proximal tubule brush border, the cells, epithelial cells, where the coronavirus can enter. So there is commonly affected organs are the intestines or and the kidneys. Now, once the endothelia are involved, and as we know that endothelia are a homeostatic organ, It is one of the largest organs in the body, and as you can know that it has the properties such as the anticoagulant or anti-aggregatory properties. It has pro-fibrinolytic properties, anti-inflammatory properties. It also acts as a barrier, these cells and the basement membrane. It has the vasodilatory function, and then there is the antioxidant property also. However, there is a damage once there is the cytokines which are being released in the alveoli, and or that the SARS-CoV-2 virus is entering into some of these endothelial cells. It may not occur as abundantly, but it does occur in the endothelial, enter into the endothelial cells, and the endothelial injury starts. So there is type 1 endothelial activation, type 2 activation. So type 1 activation is where the endothelial cells are activated, and the preformed granules or the preformed proteins are released. For example, the von Willebrand factor and P-selectin, two most important proteins which are released. And then there is a type 2 endothelial cell activation where the new proteins are formed and they are released. And these are more of the adhesion molecules and the chemoattractant molecules. And then next in the stage is the endothelial apoptosis, so that they are released from the basement membrane, or they slough off the basement membrane, a process which is known as NO-IKES. And then finally, the endothelial necrosis that happens, and that also causes the release of the von Willebrand factor, as also the thrombomodulants. So now all that is happening is the two most important things that are occurring are the presence of the P-selectin and von Willebrand factor. While P-selectin is working like a chemoattractant or chemotactic factor, and the von Willebrand factor, which binds onto the or hoists itself onto the P-selectin, is involved in the procoagulant activity. So net effect is that you will have the procoagulant effect or pro-aggregatory effect. It will be anti-fibrinolytic. It will be pro-inflammatory. It will, where the barrier function is impaired, and instead of vasodilatation, it would lead to vasoconstriction, and it would be a pro-oxidant effect, as also the neutrophils are coming along, and they will result in the release of the DNA and setting up the neutrophil exit traps in these cases. Now, once that is happening, there is a significant release of the interleukin 1, and interleukin 1 is quite like a hub because it is able to induce itself also. So it was kind of a self perpetuating cycle. There is an increase in IL-1. Increase in IL-1 would lead to the increase in nuclear factor kappa B, NF kappa B, and that is another major hub of the inflammation. When this is happening, it also leads to the release of interleukin 6, which we commonly measure in the bloodstream as the index of immunoinflammatory reaction, which goes to the liver, causes the release of fibrinogen and pi1. So procoagulant here, anti-fibrinolytic activity in this particular space. So we have got significant inflammation occurring, as also a procoagulant milieu which is starting to build up. And as you can see here, that in about first 4 days time, you will start to see a significant increase in the procoagulant and cytokine factors. And if they are higher, there is a higher likelihood of having adverse outcomes in these cases. Now, in this autopsy series, you can see that there is a significant coagulation you can see in the arteries, veins, smaller vessels, wherever. And also, now there is evidence that we would be able to identify the thrombosis in a living patient with the use of one of the platelet targeted molecular imaging, which is the fluorine 18 based GP1 or the So the ventricular, the venothromboembolism is very common, occurs in approximately 30% of the inpatients. Strokes are common. Post-mortem evidence of pulmonary emboli has been presented. The crural or the upper limb arterial involvement has been very common, unlike what you normally see in the peripheral artery disease. And then post-mortem microvascular, multivascular, microvascular thrombi are very commonly seen, which were not suspected pre-mortem. So this thrombosis leads to one of the very important features of the disease. And in one of the recent studies, which was published by Dr. Fuster from the Mount Sinai Health System, it's approximately 4,500 subjects with the median age of 65 years, where approximately half of them were females and 25% are African Americans and 25% Hispanics, suggesting that this was a diverse population. 1,000 people who were on therapeutic doses of anticoagulants, 2,000 people on the prophylactic doses, and 1,500 people who were not receiving any anticoagulants. And the study demonstrated that there was a 50% hazard ratio reduction in the subjects who were receiving either the prophylactic or the therapeutic doses of anticoagulation. Not only that, it was also presented from our studies. So this is the study from 3,000 subjects, where we looked at the extent of myocardial injury, and microvascular thrombi do contribute to the development of the myocardial injury in the COVID patients. And as you can see, that it is common in at least 33% of the subjects who present to the hospital. So the 1/3 of the subjects who have had the presence of myocardial injury, as represented or indicated by the release of troponin. But you would see that most of these subjects have a mild release of troponin. However, if we categorize it by the level of troponin release, as you can see here, that this is from left to right, there is an increasing level of troponin leak. You will, and if we see that green is the total number of the subjects admitted to the hospital, blue are the patients who recover and are discharged, and red are the people who succumb to the disease. You will see that as the level of myocardial injury increases from left to right side, the blue shaded area are the people who are recovering, goes on becoming smaller and smaller, while the people who are likely to die of the disease is increasing, suggesting thereby that myocardial injury does have a proportional relationship with an increase in the adverse outcomes. Now, when the involvement of the vessels is occurring, as you can see here in this, there is the abdominal aortic area. You can see the thrombus in there. You can also see the splenic artery, which is thrombosed in this CT scan. If you look at the arterial thrombotic occlusion in this case, there is a significant inflammation across the vessel wall. In this case, you can see it in the higher magnification. And then you will see that there is a complement deposition here. And also you will see significant amount of fibrinoid degeneration, as shown by the phosphotungstic acid staining in this particular case. So whenever we see such complement deposition in the vessels, it represents the presence of the hypersensitivity or the type 3 sensitivity in these cases. Now, when it is occurring in the microvasculature, obviously it would be leading to various tissue or organ damages as well. Now, in a once there is a virus, we know that it is into the vessel or into the circulation, and it reaches the gut as well as in the kidney. There is no reason why we should not be seeing it in the myocardium also, which is also very rich in the ACE2 receptor expression. So in this study, which was presented very recently by Christina Besso from England in collaboration with Mass General Hospital, Boston, and Mayo Clinic, Rochester, they demonstrated that in about 15 to 20% of cases, they had seen the evidence of lymphocytic myocarditis. You will see some minor lymphocytic, minor foci of lymphocytic infiltration, and some myocardial damage that you can see here. More common than that was the presence of epicarditis and also the microvascular thrombi in these cases. However, the most common was the presence of, in most of the cases, more than 80% of the cases, was the presence of interstitial macrophages, as you can see here, not necessarily associated with the myocardial damage. And most likely, these were the macrophages which had arrived there from the lungs. Now, here you can see that this is a very elegant report which comes from Dr. Tawadzi's group with a very elegant pathologist, Dr. Luisa Arbustini. And here you would see that in the myocardium, there is a presence of the coronaviruses. However, this coronavirus particles, they are not seen in the myocytes. They are found in the macrophages here. These are the plumpy macrophages, which you can see, and the coronaviruses present in them. And it looks like that these are the macrophages which have arrived from the lungs, and these must have been trapped when the coronavirus came to the alveolar spaces. You will see some of them losing their crown here, some of them in the stage of budding, as you can see here. So essentially, they are present in the myocardium, but not in the myocytes. So statement that the myocarditis is a common feature is unfounded, and it is not the myocarditis that occurs, but there is a presence of the viral particles in the myocardium. So why should it be that we have the viral presence in the myocardium? There is a significant expression of ACE2, but we do not see the viruses in the myocytes. And the reason is the lack of TMPRSS2 or the co-stimulatory molecules. Although the ACE2 receptors are significant, but since there is no co-stimulatory molecule, essentially these cells are not vulnerable to the infection by the viral particles. Else, we would have seen myocarditis in almost every patient, and there would have been a significantly higher mortality or significantly higher likelihood of having the cardiac failures than what we see currently. In this RNA master plot, you can clearly see that the ACE2, although is significantly high, as you can see here by the green bar in the heart, but when you look at the TMPRSS2 expression, as you can see in row 3, which is the heart, aorta, and skeletal muscle, you can see that there is hardly any expression of TMPRSS2, while in the colon, you can see that it is present to a significant extent, and then also in the prostate and stomach. So you can see that it is present at a very high level in the urinary tract as well as GI tract, but it is not present in the myocardium, suggesting relative immunity of the myocardium. Now, when we look at the right ventricle, somehow there is a significant affliction of the right ventricle. You can clearly see that the right ventricle is significantly greater enlargement of right ventricle, more than a 1-to-1 ratio as compared to the left ventricle. 3 of the hearts here, approximately 22 hearts, which were represented in this paper by Christian Fox. You can see that out of those, 9 out of the 22 of these hearts had the significant enlargement of the right ventricle. And it is possibly because of the cytokine increase, which is able to affect the wall of the myocardium, which is much thinner as compared to the left ventricular wall. You can also see there are minimal lymphocytes, if at all. There are more macrophages in the interstitium that you can see in the patients with the right ventricular enlargement, and also a complement deposition within the myocytes. Whenever there is a complement deposition within the myocytes, unlike what we had seen in the vessel it was hypersensitivity, but whenever there is a complement deposition in the myocardium, it suggests that there is an ischemic injury. Now, in the echocardiographic images here in a patient presenting with the ST elevation myocardial infarction like picture, but when you look at the echocardiogram, this patient had significant right ventricular enlargement. And again, in this particular case, the patient came with the normal size of the right ventricle, which increases significantly over the next 3 days. And both patients met with the fatal outcomes. And we, in our series, found that the right ventricular enlargement was one of the most important determinants of the outcomes, regardless of the pulmonary emboli in such cases. Now, the two other important features that I would like to highlight. One important is that what exactly happens after the COVID infection is gone. You would see that this is one of the reports which came from Dr. Valentina Puntman and Dr. Eike Nagel from Frankfurt, the CMR study in the subjects who had their COVID infection resolved, or they had recovered from the COVID infections. You'll see that in the 100 patients that they did the advanced CMR studies, they demonstrated the CMR to be abnormal in 80%, whether it was the increased left ventricular volume or mass. There were raised T1 times 70%, raised T2 times in 60%, this suggesting an increasing extracellular volume, the T2 suggesting the presence of edema, late gadolinium enhancement suggesting the early fibrosis was present in up to about 30% of cases. Pericardial enhancement was seen in about 20%. The T1, T2 were clearly related to the troponin scores or the troponin leak which occurred at the time of acute infection. The endomyocardial biopsy was done in the most severely involved cases as verified by the CMR, but did not demonstrate much. There were only a few lymphocytes here or there rather than a significant myocarditis, again suggesting that it is probably the microvascular thrombi or it is the cytokine excess and not the myocarditis, which indeed occurs in such cases. In the last slide here, I would like to show that there is a something what we call as the MSIS or multi-system inflammatory syndrome of children. It is quite like Kawasaki's disease, which occurs in the children which are relatively older than the typical Kawasaki. It is not typical disease like Kawasaki, but something similar where you see the myocardial affliction. In only about 30% of these cases, you may have the viral antigen still present, but most of these cases have already recovered of their viral infection. In one of the autopsies here, you would see the patient still suffers from the viral affliction, and you can clearly see the presence of the viral particle, which is in a very unusual case, which has been presented so far. The viral particle was also captured in a heart muscle cell. It is present frequently in the fibroblasts here, also in the endothelium of the left ventricle, as you can see. And here it is also showing a neutrophil with netosis or neutrophil exit traps here. And you can clearly see the area of a trap or area of the neutrophil exit trap here, the DNA from the neutrophil, which traps the or captures the organisms. Now, the difference, if you would like to see, between the infliction or affliction during the acute infection versus during the MSIS is that you see way more vascular involvement or a vasculitis type of a picture or endotheliitis type of a picture when there is a multisystem inflammatory syndrome as compared to that during the acute infection. You see very little involvement of the interstitium there as compared to the one which occurs late in these cases. And such cases are more likely to respond to the immunomodulatory therapies, such as giving the tocilizumab or other IL-6 agents or other inflammatory agents. And this possibly happens because of a hyperimmune response or because of a macrophage activation syndrome. Thank you very much.